Mr. Chairman. Thank you for the invitation to come and speak here from cardiac surgery in the special circumstances of liver cirrhosis patients. I have no disclosure. This cardiac surgery is well known as having done a lot of progress these last years, and all these surgical techniques improvement and all the improvement of post-operative care are well known. Cirrhosis remains a very challenging clinical problem in heart surgical patients. The post-operative morbidity and mortality rates remain significantly high in cirrhotic patients. This is especially factors due to liver state and cirrhosis rather than the cardiac disorder, which are responsible for the poor results. The incidence of cirrhotic patients who underwent cardiac surgery all around the world is very low. It is about 0.25%, which is not very often in our practice, everyday practice. We already talked what is liver cirrhosis. For us, the cardiovascular surgeon, this is a complete change in liver structure with a compromising intrahepatic blood flow and development of collateral. And for us also, cirrhosis is an end-stage liver disease with all the problem due to this terminal disease. We also know that survival in that situation in those patients is quite low in comparison with the normal population. The risk of cirrhosis is quite high. The American College of Surgeons made a survey in 2009, and they just take 4 target operations to make an analysis in all the United States nation. And you see that you have nearly 3 million operations in 1 year, and the cabbage is about 36% of this operation, which is about 1 million cabbage a year. The patient with compensated cirrhosis who had an operation, which is about 20,000 patients in the whole United States, and this is only 7% of the patients who had cabbage or heart operation, which is 0.1% of the total cabbage. And patient with cirrhosis and portal hypertension is still lower. In the same survey, they also see that the hospital stay is prolonged for those type of patients, and you see that for the cabbage, the mortality, if you need a cardiopulmonary bypass, the mortality is more than nearly 10 times than the usual mortality in those type of patients. For cardiac surgeon, we use the child PUG score to assess the patient. And the 3 categories A, B, C, we know that the operative mortality is increasing with the classification. We also know that the life expectancy is decreased, and you have seen that with Dr. Selema already. And if you go into the different classification, you also see that child A has a good survival after the operation, but the class C is very bad survival rate. The other score which is used routinely now is the MELD score, which is already described. And the MELD is linked to the mortality, during the cardiac surgery. And there is a cutoff of about 9.3 point in the MELD score. Below 9.3, you have a very low mortality, and above 9.3 point in the MELD, the mortality is increasing. Suman was the first to compare with the ROC the MELD and the child score, and at their time of analysis in 2004, they have seen that it is about the same. In a more recent same analysis, we've seen that now the MELD is better than the child to appreciate the risk of mortality in this type of patient, specifically cardiac surgery. If you look in the literature, there is not a lot of clinical series with more than 10 patients. There is evidenced report in the Interactive Cardiovascular and Thoracic Surgery Journal in 2010, and they just make a summary of all these clinical studies. And you see that on 10 studies, about 300 patients, the mortality in type A child remains quite acceptable, but in child B and in child C, even if the number is not so high, the mortality is nearly 80 to 100%. So their conclusion, and it's rather rapidly said, is the heart surgery outcome. This is their conclusion, but not my conclusion. Please, I will still talk a little bit more then. Okay. That if you have a child score A or a MELD score below 10, you can do a cardiopulmonary bypass and heart surgery without problem. If you have a child score B or C, it's contraindicated because the mortality is unacceptably high, and in this situation you have to favor off-pump or TAVI, so alternative type of surgery, just avoiding the cardiopulmonary bypass. So the algorithm to decide what we have to do with a patient with a chronic liver disease, you have to do a MELD or a child or MELD score, and if you have a low risk class, you can proceed with surgery. If you have an intermediate, you have to take some caution, to think about what you are doing to find alternative procedure, and with the highest class, you have to avoid all type of surgery and consider for liver transplantation if the patient is available for that. So these recommendations are precise in another paper by Ayashida, and this is the same recommendation. The problem of evidence-based is the interpretation you can do. In that type of situation, is it the cardiac surgeon playing his chorus in a jam session, or is it the case of a nice woman with primary biliary cirrhosis in the Barlow disease that you want to help? And this is the situation we can have in our everyday clinical practice. If you want to do and to help your patient, you have to think of the physiopathology of the patient with end-stage liver disease, and we have all and many talk about that. And for us in cardiac surgery, we have problem with blood coagulation and blood and bleeding stop at the end of the surgery. We also have the problem of impaired cardiac function and the problem of the management of vascular resistance. We know already that they are lowered in this type of patient. And at the end, we have to think of the lung and the kidneys, because when we do cardiac surgery, we have all these problems in this patient. And I look for papers in the literature, and there is nothing but probably this paper, which is a paper coming from Saudi Arabia, done by anesthesiasts, and they just give to me the best answer to that problem actually. They use the continuous ultrafiltration and another group, 60 patients in two groups, 30 patients with continuous ultrafiltration during the cardiopulmonary bypass, and 30 patients with the same protocol and modified ultrafiltration after the end of the surgery. And with that protocol, they had interesting results. And the first interesting results is, that there is a decrease of time to extubation. There is a decrease in the ventilation time. This is highly significant. And there is a decrease in bleeding and need for red blood, red cells transfusion also. And the other things which is quite interesting also for us, the cardiac surgeon, is that the benefit of this filtration for the good outcome of the patient is that it continues during the week after the operation. You have the effect on the left on the prothrombin time, so the effect on anticoagulation, and the effect on the platelet function and the number of platelets in this patient. And you see that it lasts for a long time after the operation, and it's helped for the whole post-operative period. So if we want to do cardiac surgery in cirrhotic patients, we are today in the same situation as Henry Ford, looking at his first car after having done his 10 millionth Ford T. But if we want to make progress and get to here, there is some work to do. Thank you very much for your attention.